So let's talk about a fascinating challenge. How do you take the incredible, near infinite complexity of the human nervous system, every single thought, every sensation, and translate all of that into a single universal language? Well, today we're diving deep into the logic of medical classification to really understand the codes that define everything from a concussion to color blindness. And yeah, that question right there really gets to the heart of it. This isn't just some academic exercise. This standardized language, ICD-10-CM, is what allows a doctor in Tokyo to perfectly understand a patient's history from a clinic in Toronto. It's the bedrock for research, for tracking public health, and for making sure patient care is as precise and consistent as possible. It's a huge task, for sure. So, at its core, you can think of ICD-10-CM as the universal language of health. The section we're exploring today is just a masterclass in logical design. It groups conditions not just by the disease itself, but by their anatomical home in the body. And this structure? Well, it's the key that unlocks accurate and consistent coding. And the way this language is built? Well, it starts by mirroring the nervous system itself. Right off the bat, the codes are split between the body's command center, the central nervous system, or CNS, and that huge network of nerves that connects the center to everything else, the peripheral nervous system, or PNS. This basic distinction is your starting point for navigating the entire chapter. All right, so with that big picture in mind, let's zoom in a bit. By looking at a few key conditions, we can really uncover the core principles that every single coder lives by. We're going to focus on three big ideas: sequencing, specificity, and the absolute importance of documentation. Okay, first up, and this is arguably the most important principle of all, sequencing. This isn't just some random rule. It's about telling the patient's story in the right order. For so many conditions, you can't just code the symptom, what we call the manifestation. You must code the underlying cause first. It's a powerful cause and effect logic that's built right into the system. And this chart, it's a perfect example of that sequencing in action. If a patient has meningitis because of Lyme disease, coding for meningitis first would be telling the story completely backwards. You have to code for the Lyme disease first. So why does that matter? Because it dictates the entire treatment plan. You treat the Lyme to resolve the meningitis. The code sequence actually reflects the clinical reality. All right, let's move on to Parkinson's disease. This is a progressive disorder that messes with movement, and it's caused by a lack of the neurotransmitter dopamine. For coders, this condition is a great example of how the system handles diseases that can pop up from different causes. The big question for a coder is always, why is the patient showing these symptoms? And yeah, the coding really does all come down to that why. If it's primary Parkinson's, the disease itself, it's a straightforward G20. But if the symptoms are just a side effect of something else, like a medication, it's called secondary Parkinsonism. In that case, you use a G21 code, and you have to add another code to specify that cause. See? It's another way the system demands the full clinical picture. Okay, now let's talk about epilepsy. It's a condition defined by recurrent seizures, but it comes with one of the most rigid, super strict coding guidelines in the entire manual. And you can see it right there on the slide. A coder absolutely cannot assign an epilepsy code just based on a mention of seizures. The diagnosis has to be explicitly, word for word, stated by a physician. And there's a really good reason for this strict rule. A diagnosis of epilepsy isn't just a code. It has these huge life-altering consequences for a patient. I mean, it can impact their ability to drive a car, their job opportunities, even their insurance. So the documentation has to be crystal clear to justify that code. The word epilepsy has to be there. No assumptions, no exceptions, period. And this is where a coder really has to put on their language detective hat. The term intractable is a key specifier, and it means the epilepsy is really hard to control with medication. This slide is basically a coder's cheat sheet. It shows all the synonyms a physician might use in their notes. So if you see pharmacoresistant or refractory, those are your signals. They all point down the same coding path for intractable epilepsy. So here's the thing. These core principles we've been talking about, sequencing, specificity, they aren't just for the brain and spinal cord. They are just as crucial as we move into the sense organs. We're going to start with the eye, which has its own unique and pretty intricate coding challenges. But as you'll see, the underlying logic stays exactly the same. So we're going to zero in on glaucoma, which is just a perfect case study for the level of detail this system demands. At its simplest, it's a condition related to pressure inside the eye. But to code it correctly, you need to know way more than just the diagnosis. You need the type of glaucoma, the stage of the disease, and which eye is affected. Okay, this table you're seeing, this is basically the Rosetta Stone for glaucoma coding. I know it might look complex, but it's incredibly logical. It guides you to the exact right code by asking a series of questions. What type is it? What's the laterality? Meaning, is it the left eye, right eye, or both? And what's the stage? By answering these, you can zero in on the single most accurate code. And here's a fantastic example of why all that detail matters so much. Let's say a patient has glaucoma in both eyes, but it's mild in the left and moderate in the right. You can't just use a single bilateral code. You have to use two separate codes to capture those different stages. And this isn't just for billing. It reflects the clinical reality that each eye might need a completely different treatment plan. And look at that. Here's that familiar principle popping up again. Just like with meningitis, if glaucoma is a symptom of another disease, maybe like diabetes, that sequencing rule is in full effect. You code the underlying condition, the diabetes, first. It's this fundamental logic that gives the entire ICD-10-CM system its structure and consistency. All right, for our last section, let's talk about diseases of the ear. We're going to see how the very same principles, that anatomical logic and clinical specificity, apply to conditions like infections and hearing loss. So now we're in the chapter that deals with diseases of the ear and mastoid process. And, you guessed it, the codes are organized in a really intuitive way, based on the anatomy of the ear itself. This makes finding the right category of code a whole lot simpler, as long as you know your way around the ear. So let's start with something like otitis. That's just a general term for an ear inflammation or infection. And the coding here, it's beautifully straightforward. It's all based on location. Is the inflammation in the outer ear, the middle ear, or the inner ear? It's a simple anatomical approach that's incredibly easy to follow. Hearing loss is another one where the code you pick really depends on the specific type. There are three main categories. There's conductive, which is a problem with the mechanical parts of the ear that conduct sound. There's sensory neural, which is a problem with the nerves that send signals to the brain. And then there's mixed, which, as you can probably guess, is a combination of both. So the first step is always to identify the type. And here we go, one last powerful example of our core principles at work. If a hearing loss is ototoxic, and that just means it was caused by a drug or some other toxic substance, you absolutely must use an additional code to specify exactly what that substance was. It's just one more way the system is designed to capture the most complete and clinically useful story possible. Wow. Okay, so we've traveled all the way from infectious diseases of the brain to hearing loss. Let's take a step back and pull together the big ideas, the core philosophy that holds this entire system together. What are the key takeaways from our journey? You know, it really all boils down to these four pillars of what I'd call the coder's mindset. First, sequence correctly. Always tell the clinical story from cause to effect. Second, be specific. The more detail you can capture about laterality, stage, and type, the more useful the data is. Third, trust the manual. It is your definitive guide. And fourth, and this is the most critical one, never ever assume. If it is not explicitly written in the documentation, you cannot code it. It's as simple as that. And that brings us to a final, kind of provocative thought. ICD-10-CM is really a snapshot of medicine today. But as our understanding of genetics, neurology, and disease gets exponentially more detailed, how will this language have to adapt? The system is a living document, constantly evolving at the very edge of medical discovery. The real challenge will be keeping the language just as precise as the science itself.